Welcome to the Irish Fertility and Pregnancy Podcast. My name is Katie and I'm on the Sims IVF team. And today I'm joined by Dr. Alex, our Group Medical Director for our Sims clinics, our lab manager, Iulian Roman, based in our Clonskee clinic, and one of our embryologists, Dr. James Richards. So thanks for coming out today, guys. So we know that fertility is often seen as more of a woman's issue sometimes, even though we know ourselves that there is a big part of fertility issues can be on the male side as well. So I wanted to ask you guys your opinion on that and kind of what are your findings from working in the fertility field. So how common is male infertility or issues with male fertility, Alex?
Yeah, thank you for having us today. Well, it all depends what kind of source you're getting that information from, okay? But generally speaking, or historically, we will say that male factor, we used to say that it would be around 35% of the causes of having an infertility. But you see, there is recent information that is showing us that trend kind of going up, and it could be up to 40 or sometimes 45% having a male factor. It all depends where you're getting that information from.
And in the kind of your dealings day to day in the clinic, would you see a lot of male patients coming through? Oh yeah, absolutely. It's one of the most common reasons. If it's not the second one that we're seeing in our clinic, it will be the third one for sure. So when we're doing the assessment, and we do the assessment of the couples, so essentially what we do is we investigate male side as well. And there's basic information that we need to get and basic testing like a semen assessment. But sometimes we are finding that that's not sufficient and we need to do something extra. But definitely, I will say that is one of the most common reasons coming to the clinic. Yeah. And what would be some of the kind of common causes of male infertility or things that can affect male fertility?
I think it's a little bit of a mix as well. So sometimes can be in relation to the sperm production per se. So the testicles, unfortunately, they are not producing the amount of sperm that is required for doing the conception, the fertilization naturally. Sometimes could be in relation to something more structural, something physical, like varicocele in the testicles. So that's the reason why it's important always to link in with an andrologist when we're having this. And sometimes could be other factors like sperm motility and so.
Yeah. And from the lab side?
So from the lab side, we deal with a lot of statistics about male factor infertility. So the most recent figures from the World Health Organization say that it's around 1 in 6 couples globally now that have some sort of fertility problem.
Yeah.
And when you break it down, it's around 30% of those cases which would have solely a male factor problem. And then it would go up to around 50% of cases where there's a contribution of male factor as well as a female factor.
Yeah.
And then we still have a lot of cases where it's just unexplained infertility that we can't pinpoint the reason with the tests that we have at the moment. But in general, male fertility has been dropping for as long as we've been recording it for. So if you plot sort of sperm count on a graph for the last 100 years, it's just falling off, which you don't know how much you can rely on the really old numbers where they've been counting, say, in the 1940s and things, but there is a general trend towards worse male fertility, and that's probably a lot of the lifestyle changes and things that have happened mostly in the Western world, all the chemicals and things like that we're exposed to.
Yeah, so things, I suppose, like, smoking and vaping and maybe unhealthy diets. Would lifestyle be quite linked to male fertility issues?
Definitely, yeah. And just the things that you're exposed to in the world these days that you don't really have any control over, like plastics. We've been through a lot of different types of plastics that have been found to have very bad chemicals in them. Everything in the food, the way that food is processed and things, all the chemicals that we expose to that way. So a lot of things are very hard to avoid, but the main things that a patient can do are the general lifestyle things like eating healthily and not smoking and drinking and things like that.
Yeah. Yeah, no, definitely. I think it's a big part of it, just minding yourself and your lifestyle as much as you can. And if someone does implement these changes, how long will it take before someone would maybe see a difference in their sperm quality if they're going to come in for a test?
Well, technically speaking, they should see, we are expecting to see some differences in about 3 months' time. So that's the period, the time required for the sperm serum to be produced. But let's not forget the sperm is only the product of the testicle, okay? So in many cases, actually, we don't see that improvement after 3 months' time. It has to be more with the long-term process because, it's not just the product. You need to, you need to improve the factory as well. So, as James said, the lifestyle, it's different. I would point out also more towards physical activity, because that's no surprise for anybody, but males in particular are way more or less active than they used to be 10, 20, 30 years ago. And that's, that the level of physical activity is highly correlated with the levels of testosterone, which is, produced in the same factory as the sperm in the testicle. So unfortunately, there are too many things. There are, too many factors that you can't just break them down and say this is, this accounts for 5% of the infertility, this accounts for 10%. It's just a mix-up, because both for males and females, the reproductive process, the reproductive strategies of their body are in the second level. So the first level of the body program is survival, and the reproduction is just on a second level. So I don't know how to explain that for males, but for females, for example, in the famine period, it was more visible. If you starve a female, first thing she loses is her period. So that's very common in the animal world as well. So it definitely has to have an impact, on the males as well.
Yeah, no, definitely. And in terms of if somebody wants to come in and get a test, what would be maybe a common diagnosis or a test that you would do with people? Like, what diagnostics would you do to maybe uncover if there is a male infertility issue?
So we normally start with a general medical history. Okay, and the reason why we do this is because sometimes there's something in the background that we need to understand if that is the reason why, for instance, semen assessment is having a low sperm concentration, you see. So we always need to do that one. It's very important to get all the medical background and all past infections, medications, and all this. After that, the initial assessment that we normally carry out will be the semen assessment. So with this one, we are getting the information about 4 parameters, which are volume, sperm concentration, motility, and morphology. And we work from there, okay? Most of the times, if we are seeing that the 4 parameters are above the standards and they're very good and quite solid, so there's not necessarily a reason for requesting a second one. Yeah. But if we doctors, we are seeing that some of them, they are like kind of borderline, sperm concentration, motility. So we definitely sometimes or many times we request a second one. And also we need to get information what's going on with that couple in relation to fertility. Sometimes you're getting miscarriage. Okay, so then can we presume that is coming from the sperm or the egg? And then of course there's other investigations such as the DNA fragmentation, fish test, and all this. Okay, but I would say that initially a good medical history with the medical background and fertility treatments, if there are some fertility treatments in the background, and semen assessment will be the initial assessment that we normally do.
Yeah, and from the semen analysis side from the lab, what would you guys be usually looking for on your end?
So similar to what Alex said, we'd get the sample in. You have to sort of let it sit around for around 15 minutes just to let it liquefy, which is a process just to break down all of the proteins that sort of globulate in the semen sample. And then we measure the volume, and we have counting chambers, which it's essentially like a small square grid in a glass chamber that we look down the microscope, and that allows us to count up the concentration of sperm cells in the sample, which is counted in millions of cells per milliliter. And then we do a count on how many are swimming. So there's 4 different types of motility that are currently being counted in the sperm sample. So we have rapid progressive, slow progressive, non-progressive, which is when they're just twitching on the spot, and we have immotile. So we have guideline parameters from the World Health Organization of where they've essentially assessed thousands and thousands of patients that are assumed to be fertile. Mm-hmm. So we have guideline values for each of these to assess whether a patient is within those sort of fertile parameters. We also look at the sperm morphology at a closer magnification, which allows us to assess the shape of the sperm cells and what percentage of the cells in a sample are normal. So for human sperm samples, it's very much quantity over quality with the sperm cells. So a sample which has 4% of the sperm cells which look normal shaped is actually considered good. Okay. So most of them look quite strange. You could have ones with like 2 tails, or they've got something wrong with them in most cases. So that's one of the main things we look for. We also use beads coated with antibodies that allow us to check for sort of immune-based infertility.
Yeah.
And that sort of gives us an overall picture of the sperm sample in terms of whether the patient needs treatment in terms of male factor infertility, and also what type of treatment would be best for that patient in terms of whether they need intrauterine insemination, IVF, or maybe ICSI.
Yeah, no, definitely. And from the treatment side, Alex, what would be, a treatment that would be maybe commonly used for male factor infertility?
Yeah, so as James was pointing, it all depends on what is the quality that we're getting from the sperm. Okay, so essentially, we normally what we doctors do, we've been guided by the lab. Okay, so essentially, they are the ones at the end that they're working with the sperm, creating the embryo and making the magic happen. So essentially, what we do is we get that advice from them, and that is the reason why most of the times I request semen assessment in our clinic, in our laboratory, because I want them to see the sperm before working with it. Okay. Yeah. So then we get information in relation to suitability of the sperm for doing a treatment like insemination, ICSI, IVF, and this. Okay. So then with that in mind, we prepare a treatment plan that is kind of the best strategy for that particular couple. Sometimes the strategy will be, if they do have time, changing lifestyle, doing consultation with an andrologist from the male side of things, karyotyping, DNA fragmentation, whatever we want to kind of assess in advance. And sometimes when it's mixed factor, because James also was saying that sometimes it's a contribution. It's not only one male factor, but we can have female and male, so that would be a mixed factor. So where time is precious, of course. So then we just we start a treatment and get the ball rolling with the information that we're getting from the lab. Yeah. So the treatments will be we will get that information from the lab, and we normally tailor the treatment in accordance to that.
Yeah, no, that's great.
Yeah, so regarding the information that you're getting from the lab, I know you're very happy about this.
Now I am. Yeah,
exactly. So we introduced recently, basically. On a single sample, we do two types of analysis. So the first one is the manual, so-called manual, even though we don't actually touch the sample, okay, with our hands. So the manual analysis that James pointed out, and now we also introduced computer-assisted semen analysis. So because the guidelines that James was mentioning, they're actually, the figures there are got from fertile population, so from about 16 countries in the whole world that actually conceived in 1 year time. Yeah. So it's not that it's not relevant, but it's not that relevant for the infertility side of things. So now we introduced the computer-assisted semen analysis because it's analysis that's more subjective. Yeah. So basically, we use the same algorithm to describe a sample. So it's less subjectivity implied, because he might think that the fast progressive are not fast enough. And I might think that absolutely fine, they're moving just well. Yeah. So now our doctors, when they receive the semen analysis report, they actually receive two reports: one done manual on the classic way, and one done by that machine. So one of the reasons why we're introducing this is because information. So we're trying to get information on the long run, and actually that machine looks at stuff that for the human eye is quite hard to quantify, like overall velocity of the sample. And like at some point we're going to put those data together, and we can create certain profiles of the fertility samples.
Yeah. Oh, that's really interesting. It's interesting having like the two to compare. And this is we don't have to use this, but is there much difference in them?
So it should be pretty close. So when we do the manual semen analysis in the counting chamber that I mentioned with the small square grid, we only put 10 microliters of sample onto that. So that's like a hundredth of 1 milliliter, which can be repeated. So you could do, say, 20 microliters overall. But a semen sample is a mixture of lots of different fluids from different organs. So you have contributions from like the seminal vesicles, prostate glands, the actual sperm cells from the testes. So it's not a homogeneous mixture. different parts of the sample could have quite big differences in terms of this amount of sperm cells that are there. So this computer-assisted semen analysis, you actually fill a chamber with around 500 microliters, and it sort of takes a measurement of that whole chamber.
Okay.
So technically it should be a little bit more representative of the whole sample, but at the same time, the way we have trained staff in andrology, so you would hope that the results are quite similar.
Yeah.
But there can be some slight differences.
Yeah. I think with, like as you said, like with human eye and stuff like that, you know, it's nice to have the both sides.
We have a program actually, you know, like we test all the embryologists 4 times a year, you know, like external a sort of external audit that's available for you know, they send samples from different clinics and you know, pictures and videos. So we do that assessment, even though we fall, you know, in the same category. There's always going to be difference because it's just like the human eye. We can't have it the same, you know.
Yeah, and from doctor's perspective, I'm so happy that they have introduced this system. Because of course we're getting patients very, very informed nowadays. So they've been shopping around. They went to several clinics. They're getting the report, and it's like, hey guys, what I'm getting with SIMS, and then they want to understand. When we are not giving them the full information, sometimes they're coming to the clinic better informed. Like, hey Alex, I read this, and I read about the WHO 6 that is only 16 or 17 countries. So it's like, how can that be reliable? That all the world has? It's like, okay, so that's probably a question for the embryologist too, but so it's very nice to have that report nowadays.
Yeah. I think, as you said, like patients are so informed now from other clinics and like resources online. Like you know, it's great that they have that available as well. But I think, as you said, like talk to the lab and kind of trust the team and the clinic as well. Like that you're in, it's really important too. But just that you had mentioned earlier about DNA fragmentation. Could you discuss that a little bit about what it is and what it's used for?
Yeah.
Well, DNA fragmentation, it's basically reflects that the process of forming sperm at some point is impaired. Okay. So there are pretty much evidence that that process happens not actually in the testicle, but in the deposit that's where the sperm is stuck after producing for about 3, 4, 5 days until ejaculation. It can be generated by exposures to several toxic factors. I mean, probably the highest DNA fragmentation level I saw, it was somebody that was working in agriculture, so it was highly exposed to fertilizers and whatever chemical treatments there. And actually after he, you know, like went away from that part, you could see the improvement, you know, like quite you know, so definitely that exposure would have been. But it's also generated by a lot of other factors. I would point out towards sleep time. So persons who don't get enough sleep, their you know, their organism basically secretes more stress hormones that actually impact on effect. And we're learning more and more that high DNA fragmentation is actually correlated with some types of aneuploidies. Those are chromosome abnormalities in the resulting embryos. Okay, so we're talking about the segmental aneuploidies that we see that, you know, we have like an increase from 3% to 5-6% in the last years. So about 60-70% of those abnormalities are actually related to the sperm chromosomes. So it's a lot of things that we're still learning about sperm and DNA fragmentation.
Yeah, definitely.
Just to add to that in terms of what DNA fragmentation means for the patient. So if you think of a sperm cell as sort of a package that delivers DNA and certain proteins and things to activate an egg and cause fertilization, but the main thing would be the DNA, so the male contribution to the baby that's formed. And sperm cells are very different to other cells in the body in that the DNA in a sperm cell sort of forms a tight crystal structure, which is quite different to the DNA in somatic cells, which is all the other cells in the body. And when that crystal structure is formed, the purpose is to sort of protect it and not allow as many sort of reactions and things that can take place in normal cells that would damage the DNA. And the sperm cells have a very small amount of cytoplasm, which is sort of like the liquid that you find in a normal cell. And the purpose of that, again, is just to make sure there's less reactions going on that can cause damage to the sperm cells. So there's all sorts of ways that DNA can still be damaged, which would be fragmentation. So along the strand of the DNA, it can have breaks, but there can be different types of breaks along the strands. And there's different tests that are being researched at the moment that measure how many of those breaks there are in the DNA. So a lot of the research at the moment is trying to work out which of those tests most accurately tells the patient how damaged their DNA is in terms of how much it has an impact on the ongoing pregnancy. So we have access in our clinic to a few different types of tests depending on the quality of the sample that we have, and that's just a constantly advancing field in terms of which test is best and how much does it actually mean in terms of the fertility of the patient.
Yeah, from doctor's perspective, so what we need to be careful about and what we also need to always have into consideration is just exactly what James was pointing. So the indication of the DNA fragmentation, that has to be relevant. I mean, and what I'm saying this is sometimes it's not like an investigation that we will do standardly for everybody. Okay, there has to be something in the background, something that in the background that we are not happy with. For instance, miscarriages, or for instance, what Iulian was saying in relation to several transfers, and then not having success. And we know that we are working with a very young female, for instance. The other thing is like the investigation per se. Okay, so there's different techniques. Some of them they just can check one of the strains or one of the chains of the DNA, which probably will not indicate potentially miscarriage, but then potentially the use of a different technique for doing the fertilization. That's that. And also, what we need to consider at the same time is that when we are doing DNA fragmentation, what we are testing is just one sample. Okay, which not necessarily is the reflection of how the testicle is performing, for saying in a way. Okay, so but that's why we all always rely on the lab to say, hey, you know what, Alex, potentially we need to look for this and for that.
Well, that's good.
And that one sample is another thing, like because the values even for the basic semen analysis are quite different from a sample to another, even from the same patient. And the curious thing what I observed looking through the Excel spreadsheet is like about 80% of the patients, they have a certain semen analysis, and when they come for treatment, they have
a different one then.
A different and usually poorer sample.
Okay? Oh no.
So that it's it's stress, it's everything, it's level of arousal and a lot of stuff that contribute to to produce a good sperm sample. But this is unfortunately this is a fact. This is why when we have borderline samples, we always say, IVF with ICSI backup.
Exactly.
We're kind of expecting, we're not expecting, but like we saw, many times that, like we had a borderline normal semen analysis, and on the day of the egg collection, we have to do ICSI.
And what are the reasons why might ICSI be used?
Well, ICSI was invented. First of all, it was not invented for men. In human infertility, was just like transposed from other science fields. So ICSI was done first in 1991, and it was for the purpose of overcoming male infertility. So basically, when you don't have enough sperm, when you have too few sperm, when you have sperm that is not moving at the level that they should move, so low motility, and when you have sperm with very bad morphology, so under those 4% that James was mentioning, we usually recommend ICSI. So the purpose of that is basically we're doing a sperm selection ourselves. So we're trying to select the best sperm in the sample possible. So we're looking at all the details. How fast it's moving, how it's moving, because it's not, we're seeing more and more, and they're actually AI starting to develop algorithms on selecting sperm based on their type of motility. And we're looking at the morphology, and we do all this under high magnification microscope. So we select the best ones, and each one sperm is injected in each cell. So actually, after the introduction of ICSI in the 90s, that was probably the most revolutionary thing that happened in the IVF lab, because poor semen samples, they don't succeed with IUI, they don't succeed with IVF, and it's just like with making sure basically that the sperm DNA package is landed in the right delivery spot.
So it's good, I suppose, to know for people as well that, like, even if they have a semen analysis that's maybe not the most ideal quality, that there is still options and things that you can do from maybe the ICSI side of things.
Yeah, and I'd say sort of the big picture for why you do ICSI in general. So sort of if you consider that a fertile normal person in a regular ejaculate might have over 100 million sperm cells ejaculated, but then you would only expect to have maybe 10 or 20 that actually get to the top of the oviduct at the site of fertilization. So it's kind of a descending scale as you go along how poor a semen sample is. In terms of when you have intrauterine insemination, for example, you would need quite a good sperm sample because you're extracting all of the motile sperm cells from that and injecting them directly into the womb. So that would lead to more sperm cells getting to the oviduct than regular intercourse. And then you'd have IVF, which is where you would have the eggs in a dish in the lab, and you would add, for a partner's sample, you'd add around 150,000 motile sperm cells, and then you're relying on those motile sperm cells actually getting into the egg and fertilizing it. So ICSI is useful in cases especially where you have lower semen parameters, where you might not be able to rely on that semen sample performing in an IUI or an IVF if it has abnormal semen parameters. And like Iulian said, it lets you pick the best sperm cells one by one and just inject one sperm cell into each egg that the embryologist would consider to be a good sperm cell that might be one that would make it in normal fertilization.
So, Julian and James, seems I have you here, and I'm just talking about the ICSI thing. So, something that I'm getting very, very common in the consultations is like, Alex, you know what? Yeah, so I'm happy to take your advice with going with ICSI, but my partner and I, we do have concerns in relation of damaging the eggs. So, you see, I normally tell them, what we know is that the probability of damaging the eggs is very, very tiny. But however, can you just tell me what would be that, how likely it is to damage an egg with an ICSI?
Well, definitely, as...
I mean, if I'm doing that one, of course, I will damage the egg, but for embryologists and this and the lab.
Well, for embryologists, I think we're half splitted, some prefer IVF, some prefer ICSI. So, but definitely for ICSI, you have a higher chance to damage an egg, because basically what you're doing, you're keeping an egg steady, and you introduce the sperm with a very fine needle, glass needle. So this is a thing that doesn't happen in a natural process. So there is a risk to damage an egg, but I can tell from my experience that the vast majority of the eggs that actually get damaged after insemination, after ICSI insemination, are the ones that you already see some abnormalities.
Okay, that so they will not fertilize.
Exactly. So even if you look at, or even if they fertilize, they go they don't progress much. Now, in terms of fertilization rates, like IVF and ICSI, it's pretty much the same.
Okay.
There's no much different in terms of blastocyst formation rate, in terms of pregnancies, it's everything the same. And there's always the argument that IVF, it's better in terms of selecting sperm because it's more closer to natural.
Oh yeah, I'm getting that every day. So
yes. Well, I would kindly disagree.
Okay.
So as Jane said, in natural fertilization, about somewhere from 10 to about 200 sperm actually reach the cell. So that's natural selection, okay?
Yeah.
And the natural selection is, they have to pass the cervix, they have to pass the womb. Both cervix and the womb have low pH, so it's actually very damaging for the vast majority of the sperm. Then they have to go into the fallopian tube, and they have to swim, in very narrow tunnel until they reach the egg, okay? So that's natural selection. When we do IVF, as you said, the concentration is about 150,000, so not 200, 150,000 sperm in a dish that might contain from 1 to 8 eggs, okay? So already the concentration is already higher. Even in the natural fertilization, you have the 200 that reach the egg. The story that the first one is the one that's going to fertilize, it's absolutely false.
Okay.
So the first ones that get around the egg, they actually just make the way for a luckier one.
Gotcha.
Because the egg is surrounded by cumulus cells, and the cumulus cells are attached to the eggshell. Let's name it this way. So it's the zona, which is a glycoprotein structure that has to be passed as well.
Okay.
So basically, if you let a single sperm, you get, I don't know, the best selection method that would ever exist. If you let that single sperm and an egg, is not going to get fertilized in 99.9% of the time. So the first ones actually just make the way for the others, and a luckier one that reaches the egg membrane, that's the one that's going to send the signal, all right, I'm fertilized, no more sperm around. So and when we are selecting sperm for ICSI, we're actually looking at some parameters that when we're selecting the sperm.
Yeah.
So I would say that's not a difference between them, and I'm seeing this both in the results, as I said, in pregnancy rates, in the genetics, when we do genetic testing of the embryos, even in the miscarriage rates. So like we have, unfortunately, we have miscarriages on both IVF ICSI and in natural pregnancy. So
true.
The selection process is not perfect. Even the natural one is not is not perfect. You have, like, if you're a gynecologist, you've probably seen miscarriages, early miscarriages, even in natural conception.
Exactly.
So I wouldn't say that's I wouldn't point out what would be the preferred method.
Okay.
And I suppose as well, from more of an emotional side of things, do you think is there a bit more stigma around male infertility, like maybe discussing it, or men coming forward to check their fertility? Because fertility can be often seen as more of a woman's issue, more so. So do you think there'd be more stigma around the male side?
Well, I don't know if there's more stigma, or it's just like the patients that they are suffering infertility, that they are handling that different. You see, I definitely see that men also struggles during treatment. I mean, probably they are not going to verbalize that. They're not going to openly say that to you, and it's like, hey, I'm having troubles with this. But sometimes we always drop the question of like, hey, you know what? If on the day of that collection you are not feeling that you can produce a sample, you can do a freeze a sample as backup, okay? And then you can see how the face changed, like, oh, okay, thank you. So that's just a tiny or just small example that how also men do suffer with infertility. Okay. But I think that it's just also the culture. Okay. So it sometimes it is expected for men to be like rock solid, and that like no showing any kind of signs of being affected with the situation, okay? But I think it's a tough process. I think that the some people think like, oh, you just need to produce a sample on the day, that's it, and that's your contribution. Is not as easy as that.
I think even supporting, like if you have a partner going through it and they have to be there to support them, from the physical side, like they might not be taking the injections themselves, but I think even like supporting from that side and the emotional side as well.
I agree. And the other thing is, like, you see, with the semen assessment at the end, or DNA fragmentation or whatever, there's always benchmark parameters. So then I have seen this, how male is like, oh, but I want to improve that here. I want to get a better DNA fragmentation next time, or I want to get a better sperm concentration. And sometimes it's not something that we can fix many times, I would say. So, but because of the fact that there's something that you can measure, so then we definitely, men, I would say that all of us, we will, I mean, if I'm the one doing the treatment, I will experience also some kind of pressure, of course, as well, to perform on the day, you see? Yeah.
And do you guys have anything on that as well?
I think, like you were saying, how the men, when we have those measured parameters and they want to have a sort of quick fix to make it better, we get a lot of the time in the lab where someone will come in with a poor semen analysis, and they'll say to us, how do I sort of improve this within the next couple of weeks before I have treatment, for example? And it's just not really the way that it works. It's like Iulian was saying, it's a long-term process, and there's no real quick fix, despite what you would see if you sort of Googled, how do I improve my sperm count? You get all sorts of like routes and treatments and things that would claim to help you within like 10 days, but it's just not true.
Not the case,
and there's no real quick fix for any of it in terms of supplements and things, because there's evidence both ways in each case, and in the vast majority there's no clear benefit to most of them. It's just a general, very long-term process of improving your overall lifestyle.
Yeah.
We also need to be very careful with what we are recommending in terms of supplements. I think like very, very common if we are seeing like DNA fragmentation is alterated. So like, okay, so you do vitamins, you say, but the problem with this is like there's no kind of limit. So the patients, they are taking like, they go over the counter and they get 3 or 4 multivitamins, and then I don't know exactly the reason, and probably Julian and James can tell me that, but sometimes it's like, actually, instead of improving, when they are taking vitamins for a long time, it's like, well, you know what? Actually, your DNA fragmentation is going the other way around. Okay, so that's why if it's something that we have evidence and we can advise and we can fix, we will do. But sometimes doctors, we need to be very careful with what we are recommending to our patients.
Yeah, definitely.
Yeah, well, so, like the thing is, we have to rely more and more on the scientific proven evidence.
Yeah.
So the reason why after taking more vitamins or whatever supplements, you might actually get a negative response to the treatment. Let's put it this way, is because you should assign vitamins if the patient has a deficiency in that vitamin.
Yeah.
So the supplements work if the patient has a deficiency that supplements might add up to. But if you're giving extra, there are very few substances in the world that are actually chemically inert to our body. Like one of them is iodine, for example. Okay, so you can have as much iodine in the body, it won't affect you. But all the others, you're just changing the balance of the. So this is a thing that we actually see a lot. Patients trying to change their lifestyle while starting the treatment.
Yeah.
And I'm just gonna lose some weight. The opinions are different. So like I would argue more that wouldn't be necessarily the best course of action, because like if you're trying to lose weight, let's put it this way. You have fat tissue, okay? You have stuff that's accumulated in the long period. Yeah. Once you lose out your fat, that stuff is going to go in the body again.
Yeah.
So, and you have no idea how that is going to imbalance the overall thing. Best course of action would be long-term health, taking care of your body, taking care of your, and actually start from a young age, because as you grow older, it's just the body doesn't respond that well anymore. So like you have to put twice the effort to gain the same results.
Yeah.
And a lot of it's, as we started the discussion, with the lifestyle. Like I was mentioning, James, like I had my first McDonald's when I was 20 years old, just because I was raised in an Eastern European country and I didn't have access to it. But until 20 years old, I ate only food that was cooked in home.
Yeah.
And now, like everything is, like everything. I buy 2 peppers from the grocery store, and it's packed in a plastic, like
you can't really get away from it then when everything's so processed. And
so
all
like
the external kind of environmental issues and toxins you were saying.
Exactly, and it's a lot to do with the food industry, and there's a lot of controversies around food and medication, and going all over the world and the internet. But like just we should follow some basic advice. You look at the components. If you see something that you don't usually have in your kitchen, just don't eat it.
So it's more effective to do any kind of changes maybe prior to treatment and set yourself up the best you can, instead of trying to do lots of changes in the middle of
exactly,
treatment.
because we can't compute how those changes are going to show up in your results if you do analysis or stuff. Of course, it's good to lower your cholesterol. Of course, it's good to lower your triglycerides. Of course, it's good to have high of oxygen in your blood and stuff like that. But changing the lifestyle suddenly and abruptly, should I say, you don't know what the short-term answer or the medium-term answer is going to be like. So, and what do you think? You're medical doctor about.
Yeah, no, I agree. So, and the other thing is like when you are doing too many changes, so then you don't know what actually
what's affecting
exactly what is effective and what is not. And the other thing is like at the end of the day, when you're getting semen assessment or semen analysis report, is what you're getting on paper. You see, it's like, oh, I want to get from 15 million to 25 million, but not necessarily means that your chances of getting pregnant naturally are going to be increased, because it's not the way it works. Okay, so there's sometimes that getting to some point like, hey, you know what, we need to do an IVF cycle because it's also a diagnostic procedure, and sometimes people forget about this, and it's just like they are very, very focused on having a better DNA fragmentation result or better semen analysis result. But yeah, so I agree with Iulian that making too many changes in lifestyle just before the treatment, that's probably not the best course of action. Yeah.
What's some kind of common misconceptions or maybe fertility myths around men's health?
I will let James to answer this.
A lot of people that go to the gym a lot and they'll drink a lot of like protein shakes and pre-workouts and all those kind of supplements, they're very bad.
Yeah.
I will agree with James, because you see some of them, I mean, probably not the ones that you can get in the EU and that they are regulated and all that, but some of them, they have substance that they are not written down there in the pot that they can potentially be very dangerous for sperm. Yeah. Yeah.
That's quite a common thing.
Yeah.
Also heavy exercise. That's not like the bigger you are, the fertile you are.
Yeah.
Because, the body has, the testicles produce an amount of hormones, of testosterone, okay? If that testosterone is used for increasing the muscular size, it's, it's nothing left of the reproductive part of it.
Yeah.
It's actually, I was having a discussion with a friend of mine while we were boxing about Mike Tyson, and I don't know if you saw footage of Mike Tyson when he was young, okay, when he was in his prime.
Yeah.
Like his voice was like, if he called you to threaten you over the phone, you're like, get out of here, like, come on, who you're trying to fool. The thing is, obviously he's he was a testosterone factory, but the testosterone went in the secondary process of the body, went all in strength, all in power, all in fitness, and actually see that high professional sportsmen, they don't have the sperm quality that they expected, and this is because basically, the usage of the testosterone goes mostly in, mostly in the muscle buildup. Yeah.
What would be maybe some advice for someone if they're kind of thinking of starting treatment, or if they're kind of thinking about learning more about their fertility? Maybe when should they come? Should they, maybe come and get a test when they're trying and nothing's happening, or maybe before they're planning?
Yeah, that's it. The sooner the better.
Yeah.
The sooner the better. Regardless if they are trying to get pregnant in 2 years' time, 5 years' time, or just starting a family, the sooner the better, because of course the more information we doctors and of course the lab as well we have, the more accurate and the more accurate we can advise, and the more we can do in general. Okay, so you see, I definitely will recommend to everybody to do a semen assessment, because you see, it's we don't know how the sample is going to be. Okay, so and it's not painful, or shouldn't be painful, to get a sperm sample. Okay, so that's the first assessment that we should do. But we normally start the other way around. We start kind of checking something in women, like doing blood tests, scan, whatever. Okay, but so the quick answer will be the sooner the better, regardless if they are trying or not.
Yeah.
Would you say something about expectations? Like, would you advise somebody? I would say, have, bear in mind, have the right expectations.
Yeah.
So don't expect that, an IVF treatment will, definitely be successful in the first attempt. The reality is, somewhere around half of the patients we get pregnant after an egg collection, so per cumulative live birth rate, you get somewhere between 50 and 60%. But unfortunately, there are always going to be cases that you can't solve. That's it.
Yeah. So I'd say in general, if you're worried about your fertility, so subfertility is technically defined as if you're trying to get pregnant for at least a year and have struggled. But a lot of cases, I'm sure Alex would agree, would be even people that have struggled for 1 year. If they kept trying for another year, a lot of those would get pregnant again. But as Alex was saying, it's always good to get yourself checked in terms of especially a semen analysis, because it's such a simple procedure and pretty low cost, just to see how you're doing as you're trying. But certainly if you have been struggling for at least a year or two, then it would be best to come into the clinic and try and work out a reason for that, and if you need any treatment to help you along the way.
I also will add to that one that it's important to get not only the information and knowledge in relation to fertility, but it's also important to understand that that there's no blaming game here. Okay, so doctors and patients, we want to work together, and of course we want to work together with the lab. So meaning that, hey, you see, sometimes it's like something that we cannot fix. For instance, low sperm concentration, but still there's treatment options, and of course we need to support patients, and we need to let them know that there's potentially nothing that they have done wrong. It's just the way the testicle is producing the sperm, and that's something that sometimes we are taking for granted. Like, I should be fertile, but we just don't know until you start trying. And nowadays with all the technology that we have, so definitely most of the times when we are working together and we are having a good strategy and treatment plan all together, so we get there.
Yeah, definitely. And I think, as we were saying earlier, like trusting your doctor and trusting your clinic, and like everyone's working together and, you know, doing the best they can for you and doing everything that the clinic can, I think is really important as well.
Yeah, I will agree. Yeah.
I mean, you know, it's a treatment. So once you get into the treatment, you have to rely on the clinic stuff. And in fairness, after you start the treatment, it's, you know, not much you can do.
Yeah, no, that's true.
And I think it would be pointless to, you know, overstress about it and overthink about it and, you know, have prolonged discussions about it. Like, the outcome is going to be there. You're going to find out the outcome either in, you know, 2 weeks after treatment, either in, you know, 6 weeks after you get the embryo transfer and you get the pregnancy test. So, you know, I'd probably be as chilled as possible about this. In the end, it's, you know, we males do a small contribution to this process, even though, as I said, it might be, you know, very stressful for some of them. But we just have confidence.
Yeah.
We have the same interest as them. So like he judges me, he judges the lab by the results. Okay, so like I want as much as possible as the patients. You know,
but I'm a good judge.
So I want to, you know, like same as the patients, you know, to have the successful result.
Yeah, definitely. And I think it's that bit as well. Like, people find it hard, as you said, when the treatment started, and there's not much you can kind of do at that point. I think people not having that element of control can cause a bit of stress. But I think, as you said, just try and trust the clinic and trust your doctors. Everyone's doing what they can, and just let the process happen is a really good.
And there's constant updates along the way, and we're always available when patients have questions along the way, how things are going and things like that. We can always just answer along the way.
That's great. Well, thanks so much anyway for coming and chatting. It's really, really useful and really helpful.
Thank you.
Thank you, Katie.
Thank you.